Okay, here we're going to talk about a physiologic approach to hyponatremia. First, we're going to briefly cover body fluid compartments. Of all the fluid in our body, 2/3 of it is intracellular, so inside of cells. The remaining 1/3 is extracellular. Among this extracellular fluid, 3/4 of it is interstitial, and the remaining 1/4 is intravascular. So over here, this is a cell, this blue thing. It should be noted that water moves across cellular membranes thanks to aquaporin channels. Also, there is a sodium-potassium ATPase. So this pump uses energy to pump 3 sodium ions out in exchange for 2 potassium ions. So potassium is preferentially kept inside of cells. Sodium is preferentially kept outside of cells. So when we add sodium to the body, we expand the extracellular fluid compartment because sodium is preferentially kept out of cells. As we expand the ECF, we expand the interstitial fluid compartment and the intravascular fluid compartment. And let's say there's some abnormal physiology such that the patient does not remain in balance. If they are fluid positive, this is how people develop pulmonary edema, peripheral edema, and elevated blood pressure. On the other hand, when we add pure water to the body, 2/3 of it will go into cells, while the remaining 1/3 will expand the extracellular fluid compartment. So now we have expanded the cell, and so normally cellular expansion shouldn't cause too many problems except in the brain. Because the brain is encased in a rigid space, the skull, patients can develop cerebral edema. So this is why we care about water balance and hyponatremia. And it should come as no surprise that symptoms of severe hyponatremia correspond with brain swelling, headache, nausea, vomiting, altered mental status, seizures, or even death. But we can't measure cell size on like a day-to-day basis, or at least by the time cerebral edema is occurring, it's too late. What we do instead is measure plasma sodium concentration, because if water is being retained in the body, it's going to be distributed equally throughout all these compartments. And since we have easy access to intravascular fluid, we can measure the plasma sodium concentration, which tells us about water balance, such that if water is retained, the plasma sodium concentration will fall as it's being diluted. So this is why it's so confusing for many people. In order to determine a patient's total body salt balance or sodium balance, we look at the volume of fluid in the extracellular fluid compartment. So that means looking at the interstitial fluid for edema or pulmonary edema, or looking for intravascular fluid overload like hypertension or elevated jugular venous pressure. When evaluating for too much or too little water, pure water, relative to sodium and other things, we just look at the plasma sodium concentration or the plasma osmolality, in which an abnormally high plasma sodium concentration would indicate dehydration. Abnormally low plasma sodium concentration indicates water excess or hyponatremia. Okay, so here's our approach to hyponatremia. The first task is to exclude pseudohyponatremia. So this is actually a lab artifact. It's not real hyponatremia. It's found when serum sodium is measured with a volume-sensitive analyzer and the patient has severe hyperproteinemia, maybe from a plasma cell dyscrasia, severe hypertriglyceridemia, or obstructive jaundice, which can lead to severe hypercholesterolemia and very high levels of lipoprotein X. These are the situations when pseudohyponatremia has been observed. Next, you want to ask yourself, is the patient truly hypotonic? Remember, we really want to work up the patients who have water excess. And so there are some other conditions where the patient's not hypotonic, but the serum sodium may have decreased due to the addition of some other osmol. And so hyperglycemia is a very common example of this. Radiocontrast and mannitol or other things, if they were just recently administered, could lower the serum sodium, but the patient's plasma osm is actually unchanged. Now the next step deserves some special attention. I think is the one that is under-recognized. So if the patient has advanced renal failure, severe acute kidney injury requiring dialysis, or ESRD, so if they have such low GFR, they actually can't excrete the water that's required, and so they'll develop hyponatremia just to retention of free water because they literally don't have enough GFR to dilute the urine appropriately enough to remain in good water balance. So renal failure, ESRD, if someone has hyponatremia, it's not really much of a diagnostic dilemma. They just literally can't excrete water. So by this point, if we've excluded pseudohyponatremia, we've proven that they're truly hypotonic, and we've ruled out severe renal failure or ESRD. Our next question is, well, are they making dilute urine? Because remember, if they're truly hypotonic, so they have hypotonic hyponatremia, they should be making dilute urine. That'd be the appropriate physiologic response to water excess. So that's our next question. So how would you do that? Well, first, you pay attention to the urine volume. You could also measure the urine osms and compare that to the plasma osms. Also, to measure the electrolyte-free water, you could measure the urine sodium and urine potassium, add those together, and compare that to the plasma sodium and plasma potassium. Using this term here, you could actually calculate the free water clearance of the patient, which you would also need the urine volume to do. So using that, you should be able to make this distinction between an appropriately dilute urine or an inappropriately concentrated urine. Remember, this patient has hypotonic hyponatremia, they're retaining water. An appropriate response would be to make a dilute urine to get rid of excess water. An inappropriate response would be to concentrate your urine and hold on to more water. And if you had to pick a cutoff, a urine osms of about 100 milliosms per kilo is a pretty good cutoff. Less than 100 milliosms would be appropriately dilute. Remember, the urine can dilute down to about 50 milliosms per kilo, so less than 100 would be dilute. More than 100 in the setting of hypotonic hyponatremia would be inappropriate. And just to make another distinction, if the urine is appropriately dilute, we've just proven that ADH or AVP, whatever term you like, is very low. So antidiuretic hormone is appropriately suppressed. However, on the other side, where we're making concentrated urine, ADH is very high. So ADH or AVP is very high and it's being stimulated. So at this point, everything in this category is going to have the same profile of ADH secretion. Everything in this category is going to have the same profile of ADH secretion. So ADH is going to be very high when the urine is inappropriately concentrated. It's going to be suppressed and very low when the urine is appropriately dilute. So here are some diseases or states where the patient can develop hyponatremia but have an appropriately dilute urine. So primary polydipsia, or a water drinking contest, is essentially occurring because the patient is drinking water faster than the kidney can reasonably excrete on an hour-to-hour basis. And so if you're drinking more than a liter per hour and keep that up, eventually you'll develop hyponatremia. Essentially, the kidney's trying to do the right thing. ADH is appropriately suppressed, but the patient, for whatever reason, is taking in too much water too fast. So next is beer potomania and the tea and toast diet, and this is hyponatremia essentially due to low solute intake with high fluid ingestion. And the daily amount of solute we ingest determines the total urine volume we can produce. And so what happens is that these patients are taking in very little solute, very little nutrition, so they have a lower limit of urine volume they can produce. If they happen to be drinking more fluid than that limit of urine volume, they will retain the excess fluid in terms of pure water, and they'll develop hyponatremia in that way. So this is mainly due to high fluid intake plus poor nutrition. So in the patients who have inappropriately concentrated urine, remember they have very high levels of circulating ADH. This is where you want to do a really good physical examination to understand the patient's volume status. So we're paying close attention to the extracellular fluid volume. We're looking for edema. We're looking at the blood pressure. We're looking at the JVP. And we're trying to make a best guess about the fluid status of the patient. So for patients who have low extracellular fluid volume, so these are people who have hypovolemic hyponatremia. Remember that ADH is secreted in response to low perfusion. So if the patient's hypovolemic, perfusion is impaired, and ADH, also known as vasopressin, is released. And so the prototypical example is a patient with GI fluid losses, let's say severe diarrhea, but they replace fluid losses with pure water. So as long as ADH is very high, they will retain that water and develop hyponatremia. Also, adrenal insufficiency, diuretic use, or severe burns with third space fluid losses. Any cause of isotonic fluid loss with replacement with maybe pure water will result in hypovolemic hyponatremia. So for patients who have a normal ECFV, so these are euvolemic patients with euvolemic hyponatremia, we call this non-osmotic ADH release. It collectively is also called SIADH, the syndrome of inappropriate ADH. And so the most common reasons for this are trauma, pain, severe nausea, sepsis. So this is quite common in hospitalized patients. Historically, it's rarely caused by ectopic ADH secretion, let's say as part of a paraneoplastic syndrome. Rarely, severe hypothyroidism can cause this, as well as glucocorticoid deficiency, but it's quite common to be seen in the hospital due to those other causes I mentioned at first. So next we consider patients who have increased extracellular fluid volume, so patients with hypervolemic hyponatremia. So we really have to consider a couple of entities, one heart failure and the other cirrhosis. These are entities where ADH is very high, and really the mechanism is the same as patients who have low extracellular fluid volume. It's all due to low perfusion being sensed in the hypothalamus and sending signals to the posterior pituitary to secrete ADH, otherwise known as vasopressin. So in the case of heart failure, the low perfusion is due to low cardiac output. In the setting of cirrhosis, the low perfusion is due to splanchnic vasodilation and peripheral vasodilation. Either way, ADH is going to be secreted, and this is a compensatory mechanism to try and maintain blood pressure, but unfortunately the consequence is hyponatremia, which can be quite severe.